So my name is Lucie Heinzerling. I'm head of the Skin Cancer Center at LMU Munich, and I treat all kinds of skin cancers, including melanoma, but I'm focusing today on cutaneous squamous cell carcinoma, which is a skin cancer of the elderly. So we often face patients with comorbidities. We also see it in patients with transplants, so solid transplant recipients. And it is not as deadly as melanoma, so mostly we have like lymph node metastasis, and we also have locally advanced disease. So by now, we actually treat from stage 2 to stage 4 with a neoadjuvant schedule. And there's also data on all these stages, and we were actually quite convinced that we have a better outcome than if we treat post-surgery. So if you treat in the neoadjuvant setting, you get a better response rate, and this is mainly due because you do not resect, for example, tumor-infiltrating lymphocytes. Also, you don't have, as an advanced disease, this tumor-suppressive tumor microenvironment. So we actually think we can improve the outcomes. Also, of course, if we have these large tumors, we often face mutilating or functionally inhibiting surgeries. Also, we can reduce surgery duration and, of course, surgery-associated morbidity. Furthermore, once we do get the surgical resected tumor, we can assess whether the patient has responded to immunotherapy, so we already have an outcome. So actually, we really like it based on the evidence that's in the literature, and we do it after we have a recommendation from the Interdisciplinary Tumor Board. And also we see more and more that also the surgeons are quite happy with the solution. So even though it's not in the German guidelines, we have seen recommendations that on a case-to-case basis, they recommend at least considering neoadjuvant therapy. So for cutaneous squamous cell carcinoma, for us, immunotherapy is the first-line treatment, and this is also based on the literature. Only in patients who are resistant, we consider combinations, for example, with cetuximab and or radiotherapy. And so we are actually very happy with our response rates in anti-PD-1 immunotherapy. Actually, this is a really good question, whether there are any markers to select the patients. I think a predictive test for response to immunotherapy is still desperately needed. And all the ones we do have actually cannot be decisive for the therapy, especially PD-L1. We do see responses no matter whether patients exhibit this marker. And what we actually do take into consideration are comorbidities. For example, solid transplant recipients, of course, they have a higher cost of the immunotherapy since they might reject their transplant. So I think the optimal treatment duration before surgery is not determined yet, so we have to define this. But I think we have data for anything from 2 to 4 infusions before surgery, and we typically do schedule the surgery 2 weeks after the last infusion. So this is what we typically do, and I think this is a very good way. I mean, it's not clear when is the nadir, when the tumor is actually shrunk the best, so we can have this R0 complete excision. But in the meantime, I think this is a feasible way to go. So basically, we can start, and then like once we've given 2 infusions, we see whether we see some clinical response, and then we can schedule the surgery. Yeah, for us, we use cemiplimab, so 350 mg IV every 3 weeks. And also in the elderly population, it is quite well tolerated. So I think this is a real upside. We've also not seen any increase in surgical complications, which I find always important to stay towards the surgeons, because in the beginning they were a little bit worried whether the wound healing would be similar to the non-pre-treated patients. And on the other side, we also don't have a good predictor for severe toxicity, which of course can occur, or also life-changing toxicity. So this would be great. And we also do not know who will have like primary resistance, because of course most of the patients do respond, but of course the ones that do progress, then the surgery could also be more extended. So there is this balance that we have to sort of keep in mind, and also of course there might also be in individual patients a not so beneficial effect. Yeah, so what we use currently is cetuximab and or radiotherapy. Chemotherapy, of course, is also an option, but what we would like to investigate further are the intratumoral immunomodulatory treatments, so basically to turn somehow the tumor hot, as it's often stated, and then basically be again successful with the anti-PD-1 treatment. Yeah, so it's actually great that the neoadjuvant therapy is so much more powerful than the post-surgical therapy or in the therapeutic setting. So we assume that basically the tumor microenvironment is not as suppressive, that the immune system is more easily primed or invigorated to mount the anti-tumor response. So we think this is quite remarkable, this big difference, that the neoadjuvant therapy is actually more effective than in the therapeutic setting. But actually, with cutaneous squamous cell carcinoma, we are happy in both of these settings because the majority of patients do respond.